I'm Dr. AJIT Pai and I'm the lead surgeon for the Gastrointestinal and Hepatopancreatico-biliary Oncology Service at the Apollo Proton Cancer Center here in Chennai. Pancreatic cancer continues to remain a very aggressive disease, and the only effective treatment, as you are aware, is surgery. Unfortunately, only about 1 in 5 patients, or about 20%, have early pancreatic cancer at presentation, which can be operated with a good outcome. The bulk of patients, more than half, present with metastatic disease where curative surgery is not possible. There is a subset of patients, about 20 to 25% of patients, who have a large tumor which is closely related to one of the major vessels around the pancreas, either the veins draining blood from the intestine to the liver, what is called the portal vein, also and superior mesenteric vein, or the artery which takes pure blood to the intestine called the superior mesenteric artery, or the blood vessels going to the liver and spleen, namely the hepatic and splenic artery. Involvement of these vessels or close relation of the tumor by more than half of these blood vessels precludes a curative resection. This is because even though the surgeon does a radical operation, tumor remains at the margin or interface with normal tissue, what is called a margin positive resection or an R1 resection, and this leads to early failure where the cancer comes back either locally where the surgery has been performed or in the liver or lungs. So this subset of patients are effectively treated with the preoperative therapy, what is known as neoadjuvant therapy or NAT, either with chemotherapy or with chemotherapy with radiation. The use of radiation significantly augments the effect of chemotherapy in shrinking the tumor and enables the tumor to move away from the blood vessels by a few millimeters, which means that the surgeon can then perform a radical operation with a negative margin. This leads to a marked improvement of outcome and longer survival of these patients. The use of high quality imaging with PET CT and CT scans and MRI definitely helps the clinician to decide which patients are suitable for surgery upfront and which for surgery after neoadjuvant therapy.
I'm going to talk to you about borderline resectable pancreatic cancer. The results of these patients has improved significantly over the last decade because of molecular testing, a multidisciplinary team approach, and also individualizing the treatment options for the patients based on their fitness level, the scans, and the molecular profile. Most of these patients at Apollo Proton are treated with neoadjuvant chemotherapy and undergo constant review and evaluation to assess response. What neoadjuvant treatment does is makes the results of the patients better because it makes the surgery safer in that the patients are able to undergo a resection with clear margins, and also we are able to assess response within the patient rather than giving chemotherapy after surgery, which we know that 50 to 70% patients are not able to receive chemotherapy. Pancreatic cancer is a systemic disease and we need to address it by giving chemotherapy, which is given in the blood and goes to all the organs. So for borderline patients with pancreatic cancer, we need to sometimes tailor the approach based on the germline testing as well, which we do in all patients, and individualize the treatment accordingly. Thank you.
Radiation therapy is an integral part of the management of borderline resectable pancreatic cancer. These patients have a high risk of disease recurrence in and around the pancreatic tumor bed. Radiation therapy helps to minimize this risk by treating the areas at highest risk of recurrence. It can be delivered with various techniques, including conventional high-energy X-rays, as well as with proton beam therapy, which is a more recent advance in this field. Preoperative radiation therapy is preferred as it enables sterilization of high-risk areas prior to surgery. In addition, it may increase the likelihood of a margin-negative resection, as tumor shrinkage can occur away from critical structures such as the superior mesenteric artery. It is also associated with reduced toxicity, as a large share of the bowel that is irradiated is removed during the surgery. In addition, preoperative radiation therapy is easier to tolerate for the patient as compared to having radiation after major pancreatic surgery. Using high-energy X-rays, stereotactic body radiation therapy is an advanced technique which delivers high doses to the pancreatic tumor and especially to the interface between the tumor and the critical vessels. Proton beam therapy, however, can, in addition to treating the pancreatic tumor, also address the regional lymphatic beds which are at high risk of harboring microscopic disease with less associated toxicity.
The presenting features in a patient with borderline pancreatic cancer are abdominal pain, yellowish discoloration of eyes, loss of appetite, and weight loss. The diagnostic tests to be carried out in a patient with borderline pancreatic cancer are the routine blood investigations, CA19-9 tumor marker, and CT scan pancreatic protocol. Biopsy plays an integral part of diagnosis in a patient with CA pancreas. The biopsy can help us to identify whether the tumor is a adenocarcinoma, lymphoma, neuroendocrine tumor, because each of these will have a different treatment protocol. EUS guided biopsy is a novel non-invasive technique which helps in getting a good tissue. Usually a FNA-B is preferred over an FNA-C because that will help us to identify the histopathology of the tumor. Patients with deranged liver function test presenting as jaundice, we usually prefer a ERCP with stenting. The stents which can be used are plastic stent and a SEMS, which is a self-expanding metal stent. The benefits of metal stenting over plastic stent is it usually prevents cholangitis, prevents the need of repeated stenting, and prevents stent blockage. SEMS is usually preferred in patients who are planned for neoadjuvant therapy prior to surgical resection.
At the Apollo Proton Cancer Center, we have the unique concept of a GI cancer management team, which means that we have dedicated clinicians like me, for example, a surgical oncologist, medical, radiation oncology, pathology, nuclear medicine, and also nurse practitioners and radiologists, who all of whom contribute and have a special expertise in treating pancreatic cancer and bring their unique expertise from all across the world to bearing on a patient who comes in. We also conduct tumor boards or multidisciplinary treatment sessions several times a week to discuss every patient who comes in, so that a collective experience gives a uniform treatment decision to the patient. This has led to our outcomes being among the best in the country. And pancreatic cancer, which is quite a lethal disease, is best treated at such high volume centers as Apollo Proton Cancer Center with a mature and experienced team as what we have here.